type 2 diabetes. All right, you guys, so let's start here. In a healthy pancreas, what is happening? So in a healthy pancreas, it produces sufficient insulin, and the receptors allow insulin to enter in the cell for energy, right? So quick recap, in type 1 diabetes, what's happening? The pancreas does not produce insulin, right? So we have to give that patient insulin by injection, right? Type 2 diabetes, this is what's happening. The pancreas may produce some insulin, but not sufficient to maintain blood glucose levels. So meaning our blood glucose is high all the way up here, right? But we only getting this much insulin, right? So it's just like I may bring the blood sugar down some, but we see that gap is not enough, right? So it could still leave that patient with their blood sugar being high. The receptors become insulin resistant. So you're like, what does that mean? So the cells quit responding to insulin. They won't let insulin do its job by taking the glucose into the cell. Therefore, the patient will develop insulin resistance. This leaves all the glucose in the blood, and the pancreas senses there is a lot of glucose present in the blood, so it releases even more insulin. Due to this, the patient may experience hyperinsulinemia, meaning high levels of insulin in the blood, which can cause metabolic syndrome, but we're not going to go into metabolic syndrome. All right, but just keep that in mind. So we remember type 1, the pancreas is not producing any insulin. Type 2, the pancreas is not producing enough insulin. All right, so this is an important slide. So what were our risk factors in type 1? I'm not answering, but you guys answer. All right, now risk factors in type 2. Age, genetics, obesity, unbalanced diet, sedentary lifestyle, smoking, hypertension, high cholesterol, history of gestational diabetes, stress, unhealthy sleeping habits. So what have you guys noticed about these risk factors? That all these are kind of on the patient, right? So remember in type 1, that patient didn't have any control over their type 1 diabetes. But with type 2, it's kind of looking like it's a you problem, right? It kind of looking like, oh, it's your lifestyle, it's your eating that has led to this. So you want to make sure that you know your modifiable risk and your non-modifiable risk. And you want to be able to teach your patients like, hey, smoking puts you at a higher risk for diabetes. So you need to stop smoking. Obesity, unbalanced diet, diets that are high in carbs, right? All those put you at risk for diabetes. So you want to be able to teach your patient about the risk factors. That's where your risk factors is where you develop your patient education. So common comorbidities that patients have. So what are comorbidities? Like if you have this disease, then it puts you at risk for another disease. So I know we just finished our cardiac chapter. So remember that diabetes basically hardens your vessels, right? And it makes the vessels hard from the glucose that sticks on proteins of the vessel, and it forms plaque. So the patient can develop heart disease, strokes, hypertension, poor wound healing from decreased circulation, eye trouble, and infections. So you want to make sure that you able to teach your patient like, hey, you know that this disease puts you at risk for heart attacks. It puts you at risk for your wounds. If you get a wound that you won't heal like you should, it puts you at a risk for infection. It puts you at a risk for neuropathy, nephropathy. It puts you at a risk for this stuff. So you want to teach your patient this, not to scare your patient, but to kind of let your patients know that this is serious. Because I know taking care of a lot of patients, and even people that I know, they really don't take diabetes serious until they're on dialysis, until they're blind. So you want to make sure that you're teaching your patients, hey, you need to be compliant. Why? because it could lead to some very serious things. All right, so how is your patient going to look, right? So they're going to have the 3 P's, right? So what is happening with polyuria? I told you guys that I was going to explain it here. So what is polyuria? This patient got to keep urinating over and over and over and over and over. So what actually is happening? So in polyuria, water is moving from high concentration. The water is shifting to the blood where the sugar is, right? So the kidneys have to then what? Filter out all this stuff, right? So the kidneys are responsible for also reabsorption of glucose. So the kidneys start to leak glucose because the kidneys cannot keep up with all the glucose. So basically, water goes to the high concentration, right? So that's osmosis, right? So where it's a bunch of glucose hanging out in the blood, right? Water is like, wait, it's a bunch of people over there. We're going over there. So what is the job of your kidneys to do? The job of your kidneys is to filtrate fluid and all that stuff, right? All right, so the kidneys then have to go to where all that water is and then excrete all that, turn it into urine and excrete all that out, right? But then your kidneys also reabsorb glucose. So if you have a bunch of glucose that's hanging out as well, guess what? It's going to take the water and it's going to take the glucose. So that's why patients may have glucose in their urine. Polydipsia, that patient is so thirsty. So the kidney is putting out so much fluid, the body needs to rehydrate itself. Don't you guys feel so smart right now? Because you're able to now tell your family member, oh, this is why you're so thirsty when your blood sugar is high. This is why you're urinating all the time. Like, y'all smart. Like, y'all are so smart. So you want to make sure that you're able to educate your patient. So polyphagia, that your patient is hungry. Why? Because the body needs energy, because it cannot get the glucose that is in the blood to go into the cell. So your patients are going to be urinating a lot. They're going to be very thirsty and they're going to be very hungry. Fatigue. Why is your patient tired? Let's think about that. Why is your patient tired? Your patient is tired because now your patient doesn't have the energy. Where does energy come from? Energy comes from sugar, but the sugar cannot get inside the cell. Your patient may have frequent infections. Why? Because yeast loves sugar. So your patient is going to be at risk for a lot of infections. They may have a lot of yeast infections going on. So you want to make sure that you just let your patient know that weight changes, heart disease, and all those different comorbidities that can come along with it. All right, so what do your patient clinically look like? So these patients tend to be overweight. It happens over time. And it is rare to see these patients have ketones, because remember that they don't have a problem with carb metabolism, right? They're able to break down the carbs, right? They just can't get the sugar to move into the cell like it should. All right, so these patients may tend to be overweight. And then you have gestational, basically what is gestational basically is a type of type 2 diabetes. And basically it goes away after birth. But what happens, the cells are not receptive to insulin. So the cells are not letting insulin bring the glucose in. All right, what are some diagnostics testing that you can do? To confirm the diagnosis, they need 2 abnormal results on 2 different days. So this is a criteria right here. So just remember, they need 2 abnormal results on 2 different days. All right, so we're going to talk about this in the next couple slides. But nutritional changes, exercise, we'll get into that. And you want to be able to educate your patient. And the biggest thing with planning stuff with your diabetic patients, you have to plan it with them. You can't plan for them, because the biggest thing with type 2 diabetes is compliance. If your patient does not comply, if you start making all these goals and all this stuff without your patient is not going to follow through with it. So you want to make sure that you plan with your patient and not for your patient. And medications, right? So we're going to dive into that. All right, so with nutritional changes, you want to make sure that your patients know what they should be eating and what they shouldn't be eating, right? That their diet should be about 50 to 60% of carbs. And then your job as the nurse is to let your patient know what are some carbs, right? What are some things that you might need to stay away from? That fats, that they should only be doing about 20 to 30%. And then non-animal sources of protein. So you want to be able to educate your patient on what they should be eating. So you're not just going to tell your patients, hey, you need to stay away from those carbs, right? Well, I don't even know what a carb is. So you want to be able to educate your patient. All right, so exercise. All right, so exercise lowers your blood glucose. And aerobic exercises are best. This helps the patient body uses insulin. So example, cardio, walking, swimming, things that is going to get the heart pumping, right? So it also helps with weight loss, with stress, maintaining that feeling of well-being, and it lowers the risk for cardiovascular diseases. So insulin normally decreases with exercise. Patients who are on insulin should eat 15 grams of carbs before moderate exercise to prevent hypoglycemia. So you want to tell your patient that if you're going to exercise, at least eat a 15-gram carb snack before. Why? Because insulin normally decreases. So what is the job of insulin? To take that glucose that we have and to push it in the cells. So insulin normally decreases with exercise. So you want to make sure that your body has enough sugar to prevent your blood sugar from dropping too low. So patients with type 2 diabetes not taking insulin or on an oral medication may not need to eat extra food before exercise. Why would they not need to eat? Because insulin is decreased. So if they don't need to eat an extra snack, because that extra snack is going to just stay there, right? Versus with patients who are type 1, their body is not producing that insulin, so it's just a difference. So just general standardized rule for if a patient is on insulin, right, exogenous insulin, they need to get a snack. Patients with type 2 and they're not on any medications and all that kind of stuff, they don't need no snack. All right? All right. So what is post-exercise hypoglycemic? Well, your blood sugar has dropped while you have been exercising. So you want to teach your patient what are the signs and symptoms of hypoglycemic. Sweaty, cold, clammy, right? Confusion and all those kind of things, which we talked about. Double vision. We talked about all this stuff earlier, right? You want to make sure that your patient know signs and symptoms to look out for. And also just monitoring their blood sugar. Just let them know, like, hey, do check your blood sugar before exercising. So one site said that if it's lower than 100, eat a small snack, and that'll help you to prevent a small carb. Eat a small carb snack, and that'll help your hypoglycemia from developing. So a hard candy, some honey, some crackers, graham crackers, some juice, things like that. So if a patient plans on exercising for a long period of time, they need to check their blood sugar before, after, and during. If the blood glucose is higher than 250 with ketone present in the urine prior to exercise, that patient needs to avoid exercising until the glucose and their ketones are stabilized. So while with a patient who has basically they would have type 1 diabetes, right? If they got ketones present, right? Or if they are super hot, we're going to get into DKA. But before we get there, so why would a patient, if their blood sugar is higher and ketones are happening, guess what's not being able to happen? Insulin is not working, right? So in patients with type 1, so their insulin is not being able to take that sugar inside the cell. So the body then starts to break down what? Fats and acids and all those things. So if the patient has ketones in their urine, you don't want, and their blood sugar is higher than 250, they do not need to be exercising. Right? They do not need to be exercising. They do not need to be burning any more fat. Any more fat. They do not need to be burning any more energy. None of that stuff, because they are already in ketosis, right? When they're starting to burn fat instead of sugar. I hope that makes sense. We're going to get into DKA a little bit later, but that was just a little snippet of it. All right, so I know we talked about this earlier, but I just want to dig just a little on metabolic syndrome. So with complications of hyperglycemic. So metabolic syndrome is not a disease itself. Instead, it is a group of risk factors: high blood pressure, high blood sugar, unhealthy cholesterol levels, and abdominal fat, which this syndrome can lead to a buildup of plaque in your arteries known as atherosclerosis. This is when fats, cholesterols, and other substances stick to the sides of your arteries. Your arteries then become clogged and brittle. Blood clots form when the artery walls are damaged. A clot can cause a heart attack or a stroke. So metabolic syndrome, this is just an overview of a bunch of risk factors that can lead to heart disease. So just want to throw that out there, because I believe I mentioned metabolic syndrome somewhere earlier in a lecture, and I said that we would go over it earlier. So just remember. Okay, so this slide right here is important. I'm not going to go through all of it, but you will. So you're going to want to be able to explain to your patient, why does diabetes affect the eye? And it tells you. Why does diabetes affect the kidneys? Why am I having numbness and tingling in my feet? Why am I cloudy in my brain? Why am I at risk for a stroke and all those things? We already talked about why it was working on the heart, but you want to be able to educate your patient on why these things are happening in the body. So that's another reason why I put this slide back on here, because this picture gave the patho behind what is actually happening. So definitely look at this. Definitely. All right, so considerations for patients with hypoglycemic. So you want to make sure that they're monitoring their blood glucose. So one thing about diabetes, this is a disease that needs to be controlled by the patient. The patient needs to know how to give insulin, how to check their sugar. So patient teaching, making sure your patient knows how to dispose their straps, make sure they know how to work their machine, making sure they know how to work their pumps. They need to know how to do everything. So when a patient is newly diagnosed with diabetes, what they'll have is a diabetic educator come by, and they basically will teach your patient basically everything. But your job as the nurse is to just reinforce those things. So you can have patients that, hey, I want to see you drop your insulin so you can give yourself the insulin. You know what I mean? And you still scan it and follow the rights and everything. And then you can document that patient administered. And then I would leave a note and say that I double checked the correct units, that the patient was supposed to get, and I did the teach back method with the patient and have them show me what they actually was doing. So you want to make sure that your patients, when they come in with diabetes, that you give them as much work as they can handle, because they need to know how to properly care for their diabetes after they leave the hospital. You want to minimize infection risk, right? Because they are at risk for infection, because yeast loves what? Sugar. Monitor for urine in their ketone. Monitor urine for ketones, right? And then you want them to know different triggers. If something triggers them to have hyperglycemia, I know a lot of patients, when they start to get stressed, right? When they are stressed, their blood sugar tends to be very high. So you want to teach your patient about different coping mechanisms and stuff like that. No, you're not a therapist or nothing, but nurses, we wear many hats. So you want to make sure that they are able to recognize their triggers. And medication management. So definitely, I'm not sure if there is an insulin slide on here, but you are responsible, because you already learned it in pharm. to be able to educate your patients on their peak times, to being able to educate your patient on when do they expect the insulin to kick in. And your job as a nurse is not just to give the insulin. So let's say your patient, their blood sugar is just being high, even though they're on a sliding scale. You could recommend to the physician, like, I'm not seeing this patient blood sugar go down any when giving them this insulin. Can we add on something before meals? Can we add on a long acting insulin? Can we add on a higher sliding scale? So it's just not your job to just give the insulin, but you need to advocate for your patient. But you can't advocate for your patient if you don't know what you're advocating on. So you just want to make sure that you have a firm foundation on diabetes, because on a floor you're going to have 6 patients and 4 out of that 6 is going to have diabetes. So you want to be able to teach your patient. Now if a patient keeps coming in over and over and over, they may need to have another visit with the diabetes educator, because they may be a lack of knowledge somewhere that the patient is not getting it, or the patient could have life really happening to them where they can't afford insulin, where they can't afford healthy foods and stuff like that. So you don't want to be judgmental to your patient, because life be lifing, right? And we really want to know why our patients are non-compliant. We just don't want to go off of the bat. Oh, you don't want to eat, blah, blah, blah. You don't want to do this. You don't want to exercise. And then you just never know that they may not be able to afford those healthy foods. They may only can afford a McDouble. They only can afford French fries. They only